Pulmonary hypertension is an extremely rare lung disorder. The blood pressure in the pulmonary artery rises far above normal levels for no apparent reason. The pulmonary artery carries blood from the right chamber of the heart to the lungs. Patients who suffer from pulmonary hypertension have blood pumping through their pulmonary artery at more than double the rate of healthy individuals.
We think pulmonary hypertension starts by the cells that line all the tiny blood vessels in the lung. And so the lining cells go from being a nice smooth surface to something disrupts it. So then the muscle starts to close down on the artery, and the arteries then start to scar closed. So over time, the vessels go from being pretty wide open to being virtually totally closed. And so the pressure to get the blood through those arteries builds up, and it becomes extremely, extremely high.
This closure in the pulmonary artery puts an enormous and sometimes deadly strain on the right chamber of the heart, which must now work harder than usual to move blood through to the lungs.
Welcome to this week's cardiology news segment. And the top picks this week are a pair of studies in the New England Journal studying a new agent for pulmonary arterial hypertension. This is an agent called Riociguat, which is a class of agents that is a soluble guanylate cyclase stimulator. So this involves the nitric oxide pathway, which is involved in pulmonary hypertension, where impaired nitric oxide release is part of the pathogenesis. This agent increases cyclic GMP and thereby increases nitric oxide and has both vasodilatory and anti-proliferative effects in the pulmonary vasculature. So for Cardiosaurus News, I'm Chris Cannon.
Signaling peptide is an important component in the progression of pulmonary arterial hypertension. In normal physiology, circulating endothelin helps maintain normal vascular tone. In PAH, levels of endothelin are elevated in the bloodstream, and the capacity to clear endothelin from the circulation is reduced. Endothelin exerts its effects by activating two distinct receptors, endothelin A and endothelin B. These receptors mediate the pathophysiologic role of endothelin in PAH. In normal physiology, endothelial cells express only the ETB receptor, and smooth muscle cells express both receptors. ETA receptors on smooth muscle cells primarily mediate vasoconstriction and cellular proliferation. In PAH, excessive stimulation of ETA receptors is thought to cause vasoconstriction, cell proliferation, and hypertrophy. ETB receptors located on the endothelial cells mediate endothelin-dependent vasodilation. muscle cells, these receptors mediate vasoconstriction. It is hypothesized that under pathologic conditions, smooth muscle cell vasoconstriction predominates due to downregulation of ETB on endothelial cells.
Is to competitively antagonize or block endothelin A and endothelin B receptors. Now, when you block the endothelin A and endothelin B receptors, endothelin 1 can no longer bind to these receptors. The normal function of endothelin 1 is to cause arterial vasoconstriction. So if you're blocking this action of endothelin 1, this means that there is going to be vasodilation, and this leads to a decrease in pulmonary vascular resistance. So, if bosentan's mechanism of action is to decrease pulmonary vascular resistance, what do you think its clinical use would be? The clinical use of bosentan is to treat pulmonary arterial hypertension.
Prostacyclins analogs dilate the veins of the lungs, reduce abnormal cells growth, and helps prevent the formation of blood clots.
Prostacyclin is the main arachidonic acid metabolite of vascular endothelial and smooth muscle cells. This potent vasodilator plays a key role in maintaining vascular tone.